So I'm going to finish up talking. I like to talk about where we've been and where we are now and where we're going. And I think 2016 is a good time to talk about that. So you've heard people talking about the new low-risk randomized trials, and for a lot of us, that has always been the holy grail. You know, could we get this technology to a point where somebody would challenge surgical results that have been great for decades with a catheter-based system? And I think we're there. I have no personal financial disclosures, but we get research funding at Duke for multiple studies. So in terms of intermediate and low surgical risk, that topic, I thought by way of outline, we talk about where we were before January 2016, what we knew, and I'm really chosen to talk about just the randomized data that we have, which is phenomenal. As Andrew pointed out, this technology and the studies that have been supported by patients and physicians and coordinators has been outstanding and really unparalleled in my mind in terms of my medical career, in terms of data that's been acquired in a randomized way. A lot of brave patients being randomized to surgery. So I thought we'd talk about where we were January 1st, what we learned this spring, and what's happening now to move forward. Specifically, I thought it was important to talk about defining surgical risk. You've heard some of that already, and it's important to know where people are in terms of their open surgical risk. We'll talk about the background of high-risk randomized trials, and Todd mentioned some of those, so I will breeze through those. What I really want to spend some time talking about is this spring's data presented at the ACC and published simultaneously in the New England Journal of Medicine about the intermediate randomized trials. Really a phenomenal trial, partner 2A, randomizing patients to open surgery versus the Sapien XT valve. A wealth of data published there, and I'd like to focus on that as we conclude. We'll talk a little bit about the intermediate registry data from S3 and then show you how the low-risk randomized trials are set up. So how do we define surgical risk? Historically, we had brilliant people in the surgical field who could define surgical risk for us, and they were pretty much on the mark. They would be able to have a good idea about who they could get through surgery and who they couldn't. But in the last decade, we've moved to quantitative measures, primarily in the United States through the Society of Thoracic Surgeons database using this STS risk calculator that you've seen other people show. And it's a great tool. It is just a tool. It's not the absolute answer, and it still requires input of people who understand the risk of surgery, and that's really through this heart team evaluation. So in 2016, we moved from individual risk assessments by surgeons to using quantitative measures and then supplementing them with judgment by the heart team. The STS database is phenomenal, began collecting data 30 years ago. A huge amount of patients put in that database, and the risk models for mortality and morbidity have been developed so that every year they look at the observed risk that year for surgery versus what they calculate with the database, and then they calibrate it and they redo the models about every 3 years. It's incredibly easy to use, and I see our residents on the floors now using it for multiple surgical operations, and it's thrilling to me to see somebody sitting at a computer with this website up that now is quantitating surgical risk like we never really did when I was a resident. The predicted risk of mortality, the risk of mortality there is a 30-day mortality risk, and that's what most people are talking about. It gives you stroke risk and other risk of renal failure, but primarily when people are talking about STS risk, they're talking about STS predicted risk of mortality at 30 days. Intermediate risk, as we talked talk about these intermediate risk trials, we're talking about STS risk somewhere between 3 and 8% in general, supplanted by the judgment of the heart team. Well, how did we get to the intermediate risk trials? I'll go through that very quickly. This is the very first one, partner A. You've seen this slide shown. This is one-to-one treatment with the original Sapien valve versus open standard surgery. These patients were really high risk. This is the original trials that were published in the New England Journal of Medicine in 2011. And the estimated risk of mortality at 30 days by STS calculations was about 12%. The primary data from the trial showed that with surgery on the left-hand column here, you had higher risk at 30 days than with the transcatheter treatment of the original Sapien system, 3.4% versus 6.5%. These are phenomenal numbers. Remember, the predicted risk of mortality in the surgical database was 12%. And the surgeon in this trial came in at half of that, 6.5%. Impressive. Very sick cohort. At a year, the primary analysis showed that the mortality was similar in those patients treated with the original Sapien system versus open surgery. Graphically shown here, you can see that at 12 months and then later at 24 months shown on this graph, the surgical mortality was roughly equivalent to that of Sapien transcatheter valve replacement. Remember, this is the high-risk cohort. It's followed by core valve a couple of years later, showing a similar standard protocol looking at high-risk patients, that is high risk for open surgery, randomized 1-to-1 to open surgery versus core valve TAVR. At this point, high risk was lower risk defined by STS. We're a couple years later, and people are starting to realize that patients are still high risk with multiple characteristics judged clinically. Now the STS risk is about 7.5% of predicted mortality in this trial. And if you looked at the primary data graphically here, what you found was actually an improvement in all-cause mortality at 1 year, 14% versus 19% with surgery. And so that really changed the playing field, because from now on, anybody in high risk is now being treated with other transcatheter valve treatment like Dr. Kiefer talked about. We're not randomizing high-risk patients against surgery anymore. They're randomized against other transcatheter valve treatments that are deemed to have better characteristics. At 2 years, the mortality difference persists. This spring, the 3-year data presented showed that the gap continues to be the same, favoring transcatheter treatment in this high-risk group. So now I want to move to the bulk of the data that's new. This is intermediate randomized, presented by Craig Smith and published simultaneously in the New England Journal of Medicine about 2 months ago. It's incredible data. I don't think it will be ever repeated. It's an intermediate risk group looking at randomization of 2,000 patients randomized to open surgery versus transcatheter treatment. That's incredible. You know, hard to randomize people into an open surgery trial, we all know that, but 2,000 patients, and they were dichotomized into those patients by CT that had transfemoral access for the Sapien XT system. Now, this is a second generation Sapien valve system, and you can see that 3/4 of them now with an 18 French system can be treated through transfemoral techniques, here shown in this category here, transfemoral Sapien XT versus open surgery, with about 1,500 randomized in that fashion. In patients that didn't have transfemoral access, they were similarly randomized 1-to-1 against surgery and Sapien XT. The primary endpoint now moved out to 2 years for intermediate risk, not a 1-year endpoint, and it was all-cause mortality or disabling stroke. I'll look at just some of the details because I think this is a very important trial to understand. It was very strictly defined still by echo criteria. You had to have severe AS both by valve area and by mean gradient. The STS risk was defined by the heart center team at the site, and the guideline was greater than or equal to 4%, and the screening committee who looked at these cases one by one on the screening calls really stuck to this 4% or greater by and large. There were exclusion criteria, and Chad mentioned all these trials exclude bicuspid valves. Typical exclusion was severe LV dysfunction, severe renal insufficiency, life expectancy for other reasons less than 24 months. This is just showing a slide of the different systems. Again, the one on the far left is what I showed you for the high-risk randomized trial. Sapien XT is the one I'm talking about right now. It is the second generation valve, and the one that's the workhorse valve currently is Sapien 3 on the right. There are differences in these valves. The stent frame's different. The one on the far left, the original Sapien, was stainless steel. The other two, cobalt chromium, to reduce the frame dimensions and still keep the same radial strength. The tissue valve is similar. It's bovine pericardium, but the frame height is shorter with XT and has been elongated with Sapien 3 slightly. The main difference in the valve is that there's a sealing skirt on the outside of the Sapien 3 valve that you've seen before. And the other major difference is that the delivery system is smaller, from 18 French with XT in general to 14 French that's with an expandable sheath with Sapien 3. The PARTNER 2 data looked at all-cause mortality or disabling stroke at 2 years, as I mentioned, and the follow-up was phenomenal, with about 98% of people with complete follow-up in this database. As you can imagine, there was some dropout in both arms randomized to this kind of treatment, and there was more dropout in the surgical arm. So 77 of the 1,000 patients who were randomized to surgery did not have surgery. So only 17 in the transcatheter treatment group withdrew. So this data that I'm going to show you will be shown as the intention to treat analysis, but also we will show you some data on the as treated analysis as well, that is patients that actually went on to surgery or Sapien XT treatment. The predicted risk of mortality, again, lower than we've seen. So again, representing an intermediate risk group, predicted risk of mortality 5.8% in both arms, and things were well matched by the randomization. 1,000 patients with Sapien XT versus 1,000 patients with open surgery. You can see that there are procedural differences. As you might expect, the anesthetic time and the procedural time were significantly lower with the Sapien XT group. The ICU length of stay was about half, with 2 days in XT versus 4 with open surgery, and the median length of hospital stay, 6 days with XT versus 9 with surgery. The procedural deaths were similar, about 1% in each group. And if you looked at coronary obstruction, surprisingly, just as frequent with open surgery as it was with transcatheter treatment with XT. Valve embolizations were uncommon, but 1% of the cases, and there were rare annular ruptures, and greater than 2 valves were used in the initial procedure, and 2.6%. This is the primary intention to treat database, looking at all-cause mortality or disabling stroke. This is surgery in yellow. This is open surgery. You can see in the 1 year or the 30-day mortality was 8% for open surgery, 6% for Sapien XT. At 1 year, 14.5% mortality for XT versus 16 for surgery, and then at 2 years, which was the endpoint, 19% versus 21, not statistically different. So to come full circle with what Sharif talked about this morning and the concern about surgery is, for the first time, we've seen surgeons not beat the predicted risk of mortality in this trial. So 8%, you remember the predicted risk of mortality was 5.8%. So whereas before the surgeons had always been coming in below the predicted mortality. This is the as treated group, and again, slightly more difference in the two lines favoring transcatheter treatment, but not statistically different. So it proved the primary intention of the trial was to show that in an intermediate risk cohort, Sapien XT performed just as well as open surgery. If you looked at the subgroup analysis, really most of the, if you look here, this favors transcatheter treatment. Get this mouse to work to the left of this line and favors surgery to the right. And most of the subgroups dichotomized by age and gender are pretty much a dead heat. But access route favoring transfemoral access seemed to be favoring transcatheter treatment if you could treat these people with transfemoral access. And so if you look at intention to treat, or I think a fairer assessment is to look as treated, this is the data for the transfemoral group. If you remember the original demographics, about 3/4 of these patients now could be treated with transfemoral access with this 18 French system. And so in that 3/4 of patients, there was actually a statistically significant improvement with transcatheter treatment with Sapien XT compared to open surgery. So intermediate risk treated transfemorally, the mortality and major stroke lower with Sapien XT compared to open surgery. At 1 year, the mortality was 11.7%, and at 30 days, 4.5%. This is the individual makeup of that death and stroke, again showing equivalence with the two treatments. If you look at individual complications, there are complications more frequent with both of these, but the one thing I want to point out is that the pacemaker rate with XT was not different, not higher than open surgery. You find that there are differences. Open surgery, higher risk of renal injury causing renal failure, and this has been seen in multiple randomized trials now as a consistent finding. Bleeding more frequent and atrial fibrillation more frequent in the surgical arm. XT is better at relieving aortic stenosis, and I think, as Jeff pointed out, the surgical frames are always narrowed because of the sewing ring, and so the valve areas are better with Sapien XT in this trial, slightly better than with open surgery. Paravalvular regurgitation, that is aortic regurgitation around the frame, is higher with transcatheter treatment. This is XT on the left at 2 years compared to open surgery. Paravalvular regurgitation really quite rare with open surgery and was seen in about 30% of patients with Sapien XT. This is information that Chad alluded to. This is the 24-month data looking at the relationship of mortality at 2 years, dichotomized by patients who had no aortic regurgitation in the blue, mild in the green, and moderate in the orange. And you see that the real change in mortality, at least at 2 years, is only seen with moderate aortic regurgitation. So in conclusion, this trial, really a very impressive amount of work, is that Sapien XT, similar to surgery at 2 years in terms of all-cause mortality and disabling stroke compared to open surgery with and XT. And then in the transfemoral subgroup, those patients that could be transfemorally treated, Sapien XT superior to open surgery in the intermediate risk cohort. Very impressive. So that was, again, April. SURTAVI A similar trial has concluded, 1,600 patients now enrolled, and that follow-up is ongoing, so keep tuned for SURTAVI. Again, an impressive randomized trial. This time, transcatheter treatment is core valve evolute versus open surgery. Again, an intermediate risk group. I think you'll find, though, that the intermediate risk group in SURTAVI may be a lower STS risk because they moved down to about 3% as an accepted STS risk with this trial. So it just concluded in May, and the data should be available, at least the one-year data, by next spring. I'll show you a little bit of the S3 data just because it's contemporary, but this is not randomized data. This is a registry of 1,000 patients, again presented at the ACC and published in The Lancet. And this looked at the intermediate risk group of patients treated with S3, the contemporary valve, transcatheter treatment either through transfemoral or alternate access. This is trying to compare this to open surgery, but the comparison really isn't relevant. I just show this slide because despite attempts to make these two groups similar, the surgery XT group really is different, more women in the surgical group and a slightly higher STS risk. But the data for S3 is very impressive. Just concentrate on the blue line. The surgical line is really the XT surgery, not a direct comparison. But 3.7% mortality at 30 days in this group, and then a 12-month mortality of 11%. So similar to XT, XT was about 4.5%, so it's even slightly better, with mortality at 1 year with XT being about 13%. So if anything, S3 seems to be even a little better. Again, most of these patients were treated transfemorally with a smaller delivery system still. Paravalvular regurgitation, similar, however, to XT, but less moderate aortic regurgitation with S3 than was seen with XT. Still mild paravalvular regurgitation in about a third. So that brings us to where we are now. And so 2016, as we're speaking here, patients are being enrolled in these two trials, which is very exciting. The low-risk randomized transcatheter treatment trials, randomizing patients to TAVR with core valve evolute or Sapien 3, two independent trials. They're very similar, so I'll just show you this one slide to sort of summarize what the entrance criteria are for these patients. They have to be low risk, so the STS risk has to be less than 3%. They're all evaluated by the center heart team and deemed to be low risk, and then they're presented to screening calls. Both of these trials will enroll a sample size of about 1,200 patients, and they'll be randomized 1-to-1 to transcatheter treatment or open surgery. The follow-up is going to move out. Now, as the surgeons were alluding to, this is a group of patients expected to have more longevity, and follow-up is going to move out to 10 years. The primary endpoint is death or major stroke at 2 years. The other thing that's interesting about these studies, and hopefully John Vivalli will get some information that's badly needed with the help of Lynn and other imagers, that there is a leaflet sub-study in these both of these trials that will study these patients by routine CT following transcatheter valve implantation. The CTs are done at 1 month and then at 6 months following TAVR. So we're going to get leaflet mobility data by CT that will be helpful to understand this question a little bit better in the low-risk trials. So thanks for a great day. I really want to thank, where's Christy Darnell?